this is the last in our series covering some of the meaningful use objectives, 4 core and one of the menu items having to do with some of the specific EHR functions, protection of data, and reporting. And some of the ones we're going to talk about in this session are really kind of fascinating to me. Not only what the requirements are, but what some of the workflow that's going to have to be deciphered out for stage 1. And kind of interesting how for stage 1, how low the bar is for some of these items. So not really a gigantic number of them to go through in this session, but some interesting ones. As we said, every other session, 25 meaningful use objectives for stage 1, broken down into 5 different kind of groupings or categories. We've spoken about those before. 15 in the core set, theoretically and technically. Eligible professionals must meet all the core objectives to qualify for the incentive payments, But we well know that there are numerous exclusions, certainly for stage 1. And then for the menu set objectives, 10 in the menu set, eligible professionals can defer 5 of those. There is a requirement that they have to do at least one of the 2 public health objectives, immunizations or public health surveillance. Each one of the objectives we're going to look at from different directions, as we have with every session. The objective itself, what the particular measurement is going to be for stage 1, and any potential exclusions. As with all the other measures we reviewed, there are really 2 types of measurements. One is just a straight attestation. Yes, you do it, or no, you don't. The majority of them, though, are percentage-based with a numerator and denominator to make sure that for a particular meaningful use objective, the eligible provider does not only have possession and has a certified EHR in front of them, but they actually use it. And we'll look at some of those, especially around problem list, how these numerators and denominators play out. Exclusions available both in the core set and the menu set for those objectives are really outside the scope of a provider's clinical practice. And that would be when there are not any eligible patients or actions for the measure denominator, certain populations that a provider may not be seeing. And the exclusions do not account against the 5 deferred menu set objectives. The ones we're going to examine tonight, which would be the 4 core and 1 menu. So we'll examine 5 tonight, and that will, over this series, this being the last one, that will have taken us through every one of the stage 1 meaningful use objectives for eligible professionals. Using the EHR functions, protecting data, and the ability to do several types of reporting. Always important to define the terms. A constant term that runs through quite a few of these meaningful use objectives is unique patient. So when there's certain percentage on a meaningful use objective, as we'll see tonight, for a problem list, there's a threshold, we'll examine details of it, where 80% of unique patients in a reportable period have something in that problem list. So we're not really looking on an encounter by encounter basis to make sure it's always there. We're just making sure that during that period that we're looking at to actually report the statistics and metrics on, we're going to just view those unique patients that we're seeing during that period of time and make sure there's something that would be in the numerator, denominator being those unique patients. Problem list, defined, CMS gives as definition a list of current and active diagnoses as well as past diagnoses relevant to the current care of the patient. Up to date, as defined by CMS, term up to date means the list is populated with the most recent diagnosis known by the eligible professional. This could come from interviewing the patient, previous records, information from other providers, and real-time assessment diagnosis by the EP. A few more definitions here. Appropriate technical capabilities. One of the cornerstones of the foundation of the certified EHR technology is that the technology works together. And the different modules for the different meaningful use objectives are not silos by themselves. The data really has to flow across these modules, so we really get the benefit of that electronic health record technology. Information from the allergy list, information from the medication list, information from demographics can be used to generate the proper kind of reports, to generate clinical decision support, to generate drug-to-drug and drug-to-allergy reports. And so we really need that technical capability to be part of the certified technology or any other outside systems that would work together, and also under the umbrella of that privacy and security of the patient records. Clinical decision support, we'll examine this in detail. It's kind of fascinating how it's playing out in stage 1. Defined by CMS as the health information technology functionality that builds upon the foundation of an EHR to provide persons involved in care processes with general and person-specific information. What this really means is that when we are entering data into a patient's record, or there is already patient clinical information or demographic information on a particular patient, that if certain rules are triggered based on that picture of the patient, data picture and information about that patient, that we can get real-time alerts. We'll talk about the details of that in just a minute. Specific conditions as defined as those conditions listed in the active patient problem list. Core objective, maintain problem lists. There is a requirement to maintain an up-to-date problem list of current and active diagnoses. And the measure here for stage 1 is that more than 80% of all unique patients seen by the eligible professional have at least one entry or an indicator that the problem has no diagnoses or problems, and this has to be recorded as structured data. And there are no exclusions. Pretty obvious what the requirement is here. They want to make sure that, and this is a high threshold, 80%, but they don't want to release those incentives unless at a bare minimum of at least 80%, that the certified EHR clinical record on a particular individual, somebody's putting in problems in there. That's probably the bare bones use of an EHR is we at least have to have an active problem list in there. And so they have a pretty high percentage, 80%. They want to make sure that those problems are getting in there. Again, no exclusions here. The denominator is the number of unique patients seen by that EP during the reporting period. Again, for the first year in the EHR, CMS EHR incentive program, it can be 90 days, whatever their first year is. Subsequent years would be the full calendar year. So it's number of unique patients seen. We're not looking at anything based on reimbursement. This is not Medicare patients or Medicaid patients or patients with no insurance. This is number of unique patients seen during the EHR reporting period. And the numerator is the number of those unique patients who have something in the problem list as structured data. It's either a diagnosis, It could be an active diagnosis, it could be resolved, it could be an inactive diagnosis, or it could just be a structured indication that the patient has no diagnosis, and perhaps they're just coming for well visits. But at least something has to be there. Now, one thing we've touched on throughout this series is where are these numbers actually coming from? Well, some EHRs have the capability to generate this denominator and can do queries to the database and know that for a particular provider during a certain period of time, how many unique patients they actually saw. And then the EHR has that ability to look at the problem list for each one of these unique patients and see if there's something there. That's an automatic measure calculation. Some EHRs, this is a totally manual process. And there has to be some other way that your office or the other provider or somebody has to come up with this numerator and denominator. Stage one, kind of surprising they allow certification based on just that manual ability where somebody just has to put in numbers. So I have to do at least 80% there. Kind of interesting that this data, these diagnoses must also be codified. The EHR incentive program itself did not specify the use of IC9 or SNOMED coding for the diagnoses to meet this, but the ONC has adopted both IC9 or SNOMED, either one, for certified EHR technology. So when an EHR is certified currently, they examine that problem list and make sure that those diagnoses are going in codified, either IC9 or SNOMED. And so that really is a requirement. To meet this requirement is that problem lists must be codified. We already mentioned that if you have no current or active diagnoses, there still must be something in the problem list indicate that no problems are known. The real desire here is to make sure that somebody in a healthcare team is doing something with this problem list, putting something in there. The eligible provider is not required to update the problem list at every contact with the patient. It's up to the eligible provider to totally, as always, use their judgment in deciding when to update or if it is indicated to update that problem list. So for the meaningful use objective, again, that denominator is all unique patients, and that numerator is if there's something in that problem list, no correlation or anything that having to do with meaningful use as to how often that problem list is updated or viewed. It just has to have something in it for at least stage one. And the initial diagnosis can be recorded in late terms and later converted to standard structured data, or can be entered using standard structured data. I've seen a number of eligible professionals who document it in an EHR in a certain fashion, and then they have somebody who works with them, sometimes called a scribe or some other position like that, who maybe updates a very generic diagnosis with one that's more specific and is codified. So that's kind of what they're referring to right here. The next objective, and this is a core objective, is clinical quality measures. There is a requirement to report ambulatory clinical quality measures to CMS. There are 3 core quality measures, 3 alternative core measures, and then 3 additional. And so providers are required to, if it's outside the scope of their practice for the 3 core quality measures, then they have to maybe pick 1, 2, or 3 from the alternative core, and then an additional 3. So they have to report on 6 quality measures. I'm not sure how many on the phone have delved into this whole issue of clinical quality measures, but I'll give you one of the core ones just as an example. There's a clinical quality measure, I believe it's NQF 0041, which has to do with immunizations, adult immunizations, flu shots. And it's an attempt to find out what percent of patients over the age of 50 were given a flu shot. So there's a denominator that is generated by unique patients seen during a certain period of time who were over the age of 50. And then the numerator is the number of those who were received influenza immunization. And a EHR can usually generate that by either checking for procedure codes, CPT codes, or having a checkbox in the system where it would be checked or something like that. Of course, for many specialists who do not give immunizations, they would report a 0 because it's kind of outside their scope, and it's fine to report a 0. But these quality measures cannot be deferred. They cannot be excluded. They have to be reported by everybody, but it certainly is okay, as CMS tells us, to report zeros. Not percentage-based. This is attestation. Yes, you are able to generate and report these quality measures. For 2011, though, the reporting is going to be through attestation. The provider is permitted, but certainly not required, to limit the quality measures to come out of those patient records which are being maintained with a certified EHR technology. And every complete EHR that has been certified has been tested and has passed the capability to do the 6 core or alternative core objectives, and then at least 3 more. So they've been tested and proved that they can generate relatively valid quality measures. Attesting to the measure of this objective really means that the eligible professional will be able to submit complete quality measure information as required during the attestation process. And so there is not going to be a requirement in 2011 to submit this electronically, but during attestation, the numerators, denominators, and exclusions for individual clinical quality measures will be reported. Since we're going into the details, I'll mention what exclusions would be here. If I was an internist or general practitioner, saw a patient over the age of 50, that'd be my, during a certain period of time, that'd be my one unique patient. If I gave them a flu shot, that'd be a denominator, that'd be the numerator, so it'd be 1 over 1. However, if I was getting ready to give the patient flu shot, which is probably a pretty good thing to do for my patients over the age of 50, if they were allergic to eggs, or if they said that they had their flu shot last week at the pharmacy, then I would exclude them, and so they would not be calculated in the denominator, because then the percentage would kind of work against me, because it would look like I had not given them the flu shot, but actually there's a reason that they should be excluded, because they're either allergic to it or they've already gotten it somewhere else. So there is the capability to have exclusions of these quality measures. We've got the CMS has a very detailed quality measures resource website. If you're ever interested, you can go to that URL. I actually am probably there once a day as I'm working with different EHR vendors. And for every one of the ambulatory or eligible professional quality measures, I want to say there's somewhere between 40 or 50 of them. The very, very detailed specification of how to arrive at the population, what the calculations are, and what the exceptions are right there if you're ever so interested in looking at that. Every certified complete EHR has had to go into that very, very deeply. The next objective is clinical decision support rule. This one is really fascinating to me. The objective is that there's a requirement to implement one clinical decision support rule relevant to the specialty, or else a high clinical priority, along with the ability to track compliance with that rule. But the only true measure of this is that an eligible professional must implement one clinical decision support rule, and there are no exclusions. Attestation requirements, this is either yes or no. Either that rule is turned on or that rule is not turned on. And since this is core and it cannot be deferred or excluded, it must be turned on. Now for stage one for certified technology, to get certified for clinical decision support, an EHR must have one or more clinical decision support rules in the system, and it must be demonstrated. And those clinical decision support rules have to cover 4 different data elements: demographics, problem lists, medication, and lab test results. So to get for an EHR to get this module certified with clinical decision support, they can create as many rules they want to, or they can create as few as one rule that would cover all 4 of those different data elements. And there's a requirement that when that rule is met, a real-time alert is generated. By real-time, that's defined as during the actual clinical encounter. So I'll give you an example of one rule. A rule could be that, again, this is pretty much positive for an internist where this rule would fire, but a rule could be if a patient is over the age of 50 and has a diagnosis of heart disease, is on Lipitor, and has a LDL test result over 110, then I want some type of alert or pop-up that tells me something. It's totally up to the EHR technology to set up these rules, and for the purpose of stage one, there's really no requirement that these rules be terribly relevant to a particular professional or to a specialty. There's no certification requirement that a certified EHR gives the end users or the providers the ability or some type of engine or interface to create their own rules. And in fact, an EHR can get certified by creating, as I said, one rule, covers those 4 different data elements, and they can hard code this and embed it in their system. Now imagine when we get to stage 2, the requirement is going to be much more robust. It's going to be the capability for certification requirements for providers to be able to create their own rules. Some very good EHRs have a lot of maturity in this area and have very robust interfaces where practices and providers can create their own rules and alerts. But your EHR may just have one rule in it that generates an alert, and it may not be particularly clinically appropriate or relevant for stage 1, but we've got to keep it turned on anyway. Some additional information about clinical decision support. Kind of funny to me. CMS just says they will, they're tired of questions. They will not issue additional guidance on the selection of appropriate clinical decision support rules for stage 1 meaningful use. They're through with it for stage 1. This determination is best left to the eligible professional, taking into account their workflow, patient population, and quality improvement efforts. So really, what they've said is that we've made sure that at least the very baseline foundation logic is in certified technology for stage 1, and we're going to make it a lot better. We're going to require a much higher threshold for this clinical decision logic to be in systems. This is really where we, maybe in stage 3, we're going to be running a marathon, but clinical decision support right here, we're taking our first baby steps. Drug-to-drug and drug allergy interaction is not considered to be clinical decision support for this meaningful use objective. It certainly is clinical decision support, but since that happens automatically, usually through an e-prescribing partner for those drug-to-drug and drug-to-allergy interactions, they want to make sure that the clinical decision support is separate from that. And so we do have to have that drug-to-drug and drug-to-allergy interaction checking turned on. It's yes or no, and it must be yes, and one clinical decision support rule. Again, your EHR may have that rule in there, and there's not much you can do about that. Stage 1. Core objective to protect electronic health information. This is one that there's some confusion around. When the HIPAA requirements first came into being, and everybody was worried, what does HIPAA mean, what does it not mean, how do we do annual HIPAA analysis and risk assessment? This is no more complicated than that. The objective is that the protection of the electronic health information that's created or maintained by the certified EHR through the implementation of appropriate technical capabilities. And what we have to do, the measure is to conduct, this should be done at least on an annual basis, or review a security risk analysis to identify any potential risk and deficiencies and make adjustments based on those and to document. At the High-Tech Answers website, there's a lot of good information about and some links to some very good online resources and some templates that will help a practice generate one of these risk assessments and a security review. Some really good checklists, such things as, are you making backups? If the hardware is on the premises, is it in a proper environmental space? Are passwords used? A number of software and hardware security items, more than we can go into right now. But there are not really a big thing. It just needs to be done. And like I say, at High-Tech Answers, there's a couple of good links to some government online templates and resources to how to do this, and it should be done on a regular basis. And it's important because this cannot be excluded, and it must be done. So it's good practice, and it's required. And again, certain requirements are pretty clearly stipulated, and this is yes or no. And we're going to say yes, and we need to say yes. The timing, to conduct or review this security risk analysis, the certified EHR, and really the whole environment that's around the electronic health record, at least once prior to the end of the EHR reporting period, and we have to attest that that's been done. Testing can occur prior to the beginning of the first EHR reporting period, but every reporting period, this needs to be done again. If any deficiencies or risk are identified, then some type of corrective action, security update, changing the workflow, or how backups or other things, or storage methods, but we need to do those corrective actions as well as document the deficiencies and what was done to correct those. The next objective, and this is a menu objective, is patient list. for the requirements for a certified EHR, it's necessary to test and demonstrate some pretty robust generation of patient lists. But for the eligible provider, the threshold is quite low for stage 1. The requirement, the objective is to generate lists based on specific conditions to use for quality improvement, reductions of disparities, research, or outreach. Of course, when we actually generate these lists, they don't have to be for those particular reasons. We just have to generate these lists. The measure is that at least one report during the reportable period listing patients of a particular eligible professional with a specific condition. That could be a list of patients with a glaucoma, with diabetes, or whatever. Just being able to generate that list. It's really just a search of your patients, generating lists based on diagnosis. And no exclusions for this menu objective. No percentage measurement here, just attestation, yes or no, that we generate that one list. This objective, certainly for stage 1, though I'm sure this is going to be a higher threshold for stage 2, does not dictate which reports that must be generated. It's really up to the eligible professional to determine which reports would be meaningful. I can imagine that for some particular professionals, they might want to generate a list that's based on diagnosis and then have that generate some type of percentage breakdown. Kind of see what type of patients they're actually seeing, viewing them from the through the view of diagnosis. And the report can be generated for every patient whose records are maintained using the certified EHR or subset of those patients. Really, this is really up to the discretion of the eligible professional. I think this is the step 1 in trying to coach and coax the EPs into analyzing their patient population. And the report can be generated on records only on those patients who are being maintained with a certified EHR technology. Carol, we did a good job, even though we started off a little slow. We
we sure did.
There.
Or you did.
we covered well. Some of this ones tonight, and I'm really glad we were able to go ahead and do it. Didn't have to record it and email it out because some of these are kind of fascinating. Summing up all the meaningful use objectives that we've reviewed over these 5 sessions, some of them are extremely pertinent and brings great value immediately. These interaction checkings, e-prescribing, things that really bring value to a clinical environment, make things work better and provide better health care. Some of these other meaningful use objectives, we can see they don't seem to make perhaps a lot of sense right now and may not bring real value right now. Clinical decision support and being able to exchange some of these interoperability documents and files. But there are things that will kick in. We're really on a ramp here, and at stage 2 and stage 3, we'll start getting the benefit from those other meaningful use objectives. We've talked about the resources. Certainly, High-Tech Answers is probably the largest online vendor-neutral resource for hospital-eligible providers. For a lot of frequently asked questions. Usually we can get responses back from CMS within a couple of days, and more information is being stored there, and glad to be a part of that. So with that being said, Carol, I'll turn it back over to you and see if we have time for a question or two.
Yeah, we get time for a couple questions. And so the first one is, if a provider is doing MU through clinical quality measures, does this exclude them from also receiving PQRI in 2011, 2012, and so forth and so on?
I don't know if Roberta is still on the line there.
She is.
Okay, because I frequently get this confused because I think there's a difference between whether for the EHR incentives we are in the Medicare program or the Medicaid program. Roberta, can you? I don't know. You may not be able to talk. Looks like she's going to.
Yeah. Oh, she's saying you're correct. She's saying you're correct.
Well, I don't know what I said that I was correct at. Well, it may, what it may be is it depends on whether you're in the Medicare EHR incentive program or the Medicaid EHR incentive program. It varies whether you can do that double dipping to do the incentives as well as do the PQRI incentives.
Got it.
Okay.
Well, I just made Roberta a panelist and unmuted her, so if she wants to weigh in on that, she can.
Are you there, Roberta?
Yeah. So next question is, what if the CDS rule is turned on in an EHR but is not relevant to the provider's patient group? This is a clarification issue. It just needs to be turned on, correct?
It does need to be turned on. Yep.
The button needs to be in the on switch.
Right. It really does. And I think this is going to be one of those nagging little things in HIT adoption, is that we have to keep it turned on. You know, just the workflow of what we're going to have to achieve meaningful use. It's got to be turned on. And even if it's not clinically irrelevant, if whoever supplies your EHR, if they've just hard-coded one clinical decision support rule in there, it's going to be there. Now, however, if it's not particularly pertinent to you, again, if the one rule they put in was patients over 50 with heart disease on Lipitor with LDL over 111, it may not fire too often if you're a urologist. So if it's not particularly pertinent, there's no requirement that these rules ever fire. It's just that the logic is there, so if the conditions are met, it would fire. So
got it.
But that'll just be turned on.
Yeah, right. The attendee that asked that question about whether you're excluded from PQRI if you do MU said they take Medicare. They fall into the Medicare bucket, not the Medicaid bucket.
Okay. All right. Good. Right.
So if you take Medicare, PQRI is excluded. They're excluded.
You know, I always go backwards, so I'll have to look that up.
Yeah. With that, I'm going to add. Well, I'll add that question to the FAQ just so we can clarify if it's Medicare or Medicaid.
Okay. Please do.
Yeah.
Please do.
Since Medicaid gets all the breaks, you would think that.
Well, the reason why I sometimes get a little confused is because it's not only the PQR reporting, but e-prescribing. Because,
right.
So depending on Medicare or Medicaid, you can possibly double dip on that. But I'm not sure if it's Medicaid or Medicare. So.
Got it. We'll get that qualified. Roberta just chatted and she said no double dipping. So.
Okay.
On Medicare, no double dip, no. So that answers that Medicare question.